very much. A lot of ground was covered by excellent presentations. And now I guess the floor is open. I think to sum them all, you all gave excellent summaries of your presentation. Thank you very much. But I think it seems fair to conclude also that there seems to be a shift from no to conditional, plus no to contextual. And with that very brief summary, I would like to open the discussion that was already started, as I said, this morning. Anyone in the audience that has questions or observations, please identify yourself and state whether you have a conflict of interest or not. Yes, please go ahead.
Peter Singleton. I was just interested on this question of how the dreaded European data protection regulations might affect this. Obviously, on the one hand, someone could make use of their subject access request rights to ask for the information that's held, though that might be affected by anonymization. But I was thinking more the intended facility for data portability. Someone might say, well, I want to have my DNA data so I can take it to somebody else to analyze, perhaps. So that was my question. Any implications there? And I was saying no feedback might be the ethically correct thing, but it may be the lawyers will force it upon us.
Okay. Anyone in the panel who wants to?
So you're thinking about raw sequence data potentially just being handed over with no interpretation because there's a responsibility to just provide data.
The certainty it seems the portability is just giving the data so I can give it to somebody else to process. There is the subject access request has got the indication it should be in sort of human readable or interpretable format, which is a bit taking further. So it's not clear how that will play out.
So, I mean, I've gathered a bit of empirical data on what people, think about being given raw sequence data, and found that there was quite a lot of interest actually in receiving raw sequence data. And when I asked, what would you do with it? Some people said, I would take it to my GP. Okay, good luck with that. Other people said, I actually wouldn't do anything with it. I would just put it in a drawer and keep it. It's mine. It's just about me. It's part of my identity. I'd put it on a T-shirt. I'd make an artwork out of it. It's just part of me. So it wasn't a sense of actually feeling very strongly about interpreting it. It was just about DNA being me, really.
Maybe from Dan, do you have any observations? Because another remark that was made by Mr. Singleton was about, the lawyers will decide. How did you do that in Framingham? Because if I might quote actually from your book, which is an excellent read, they say they had some complications in the beginning. For example, when the researchers wanted everyone to have the information they had on the risk factors for heart disease, reportedly, at times they wanted to shout from the rooftops, quit smoking or lose weight, but all they would say was, see your physician. Is that the policy that you still stick to? And if so, then...
Yeah, thank you for the question. I hope you can hear me again.
Yes, you can.
Our policy is to inform participants about any test results from coming to our clinic or follow-up blood tests that we may obtain if they're clinically actionable. Again, as I indicated, for genetics, there were a series of 4 separate criteria in terms of test validity, clear association with disease, a substantial relative risk, a health burden, and actionability in terms of treatment will have beneficial effects. We don't notify people simply because of risk when it comes to genetics. And in terms of any type of test or blood test that is routinely part of conventional medical assessments, that would be something, as I gave the example of blood pressure in our clinic, or blood glucose level, or blood lipid levels. We routinely return the results of those tests to the participants because it's the same sort of test that would be done in clinical practice. We also have examples where participants receive the result And unless they object to it, we give results back to them for things such as their bone mineral density testing. We feel that providing that information, whether or not it's actionable is a matter of debate, would result in participant appreciation, and we think that's good for participant retention.
Okay, thank you very much. That's an important issue, I think, participant retention. You had a question, yes. Please identify yourself.
My question is two-part. One part is that we have to think about the difference between the research setting and the clinical test setting. It is very important to know how careful the clinical research, clinical testing laboratory care about their samples. And I have been working in a laboratory setting, and they are two very different to each other. So even companies are very careful of testing. 1 in 10,000 a mistake could happen. And so these differences should be care about it. So and also that relate to the clear certification in the Framingham laboratory. So if you clear Clinical Laboratory Improvement Act setting, or if you return the result from the research laboratory quality grade, that is difference. And relating to that, the imaging or things, X-ray or the ultrasound testing of the artery, these are done in clinical setting. So the filing of the data should be different from filing in laboratory setting. So that my question is these differences between the research setting versus clinical testing setting, are they differently count in the feedback argument or the discussion?
Is it a question to anyone in particular in the panel, or just general? Sheila, do you want to comment on that?
That certainly does come up, and in terms of validity of the information you will be providing. And indeed, one of the reasons for this review of the first 1,000 images is to assess kind of how they are interpreted when it's the difference between a radiographer and a radiologist. In terms of care about sample, well, UK Biobank very much care about all the sample and are working in terms of access and carrying out assays themselves with that in mind. So that idea that depletion or degradation of sample would be hugely detrimental to the biobank.
Okay. And Dan, do you have any observations because the question also related to Framingham?
Yes, thank you. We feel that we have an obligation to notify participants, even if the test was done as part of a research setting, as opposed to a clinical laboratory test. When an abnormal result comes back, there's certainly a very high probability that the test is really abnormal. What we do in our letter of notification to participants indicate that this test was obtained as part of a research study and is not does not take the place of a clinical laboratory test. And if indicated, the test should be repeated before a clinical intervention takes place. And I think that's a way of allowing us to have it both ways, make it clear that this is useful for research and may not be sufficient for clinical decisions, and that allows us to notify the participants the follow-up test to be performed that will allow the initiation of an appropriate treatment. And we have many examples of that from imaging, where incidental findings may come back from a chest CT of a thoracic aortic aneurysm that someone may not have known about, or a test for an abnormal vitamin D level, or a genetic test result. I gave the example of hemochromatosis. We do notify participants that this was done as a research study. I know that our IRB is quite concerned that there may still be liability, because if we're creating the notation of notification, we assume the liability for failure to notify. But nevertheless, when we do have abnormal results, we notify, but with the clear caveat that this was a test that was done for research purposes and does not take the place of an appropriate clinical test for the same thing.
Well, thank you very much. Many more questions. Paul.
Yeah. Paul Burton, University of Bristol. Anna, that was a really interesting and lovely study. One of the things, so two studies that I'm particularly involved in terms of data access, ALSPAC and the 1958 birth cohort. In both of those, we have the situation where we've said there would be never any feedback on genomic work. But on both studies, we also have this feeling that the background has completely changed now, and therefore we recognise that there could be a situation, say, in a year's time, when a situation does arise that we feel we do have to feedback. One thing I wasn't sure of in your presentation, and I'm sorry if you said this and I didn't see it, how many people actually said that actively they did not want to be fed back? Was it a common response, that?
No, there was hardly anybody who said they didn't want data.
Okay, so that's right. So that's quite interesting. So even if we did get put into a position where we did have to go apparently against the consent, it would appear that empirically we're unlikely to be. Okay, that's
so
really
in
helpful.
terms of serious actionable conditions, it was 96% of the whole sample said that they would want that information. No, there was no. Nobody who said that they actively wouldn't want absolutely anything.
Okay.
But I think we always need to bear that in mind as a possibility. There are always going to be people that would opt out of everything, one would assume. We just didn't capture it. Yeah.
Yes, please go ahead.
Yeah, so Anna, your Sanger survey and Catherine's Wellcome Trust survey, how did they marry up? Because presumably you asked some quite similar questions, but you used quite different methodologies.
So they were happening concurrently. So I set up the survey to run through 2012, and they were gathering data. Catherine, do you want to say anything about that? They were gathering data in 2011, 2012, so there was overlap. There were, we were both working together in the design of our individual studies, and we were talking to each other, so we knew what each team was looking at. Do you want to say anything more, Catherine, on that?
I think you've covered it. I think we did. Yeah. I think we did talk to each other, but your scale of your study was. I mean, we wanted to make sure we had similar questions and we weren't contradicting in the way we worded the questions. Yeah. But I think you had a slightly different aim to what we were aiming to do. So I think we did talk and make sure that they were analogous. But
and clearly the Catherine's study was UK based and mine was international, and also they used focus groups and I didn't. It was purely quantitative. But the next phase of my study will be qualitative, so we'll have some mixed methods in there.
I was particularly interested in the feedback from the public. So so when the condition might not be treatable, does the methodology, if it's more deliberative, there's more explanation, does that make a difference to how people feel about it? So
I didn't gather the subtlety on that in mine, I'm afraid.
And the answer is yes, John. Yes. The more you explain it, I think. Is it on? Yeah. So the more you explain it, we were careful to give long explanations and different examples to ensure that people were understanding the different types of examples. So I think when you first gave the example without any explanation, there was an automatic yes, give the results back. When you gave a more detailed and more nuanced explanation, people would then thought more about it and didn't necessarily want everything back. I think that's when they steered more towards the treatable. So definitely the more nuanced, it was different. The more you explained it and the more background you gave, you got a different response.
We actually did find the same thing. So I designed the survey so that it would be an educational experience as well. So if you knew absolutely nothing about genomics and you just thought, oh, there's some films here, I'd just quite like to learn about this, what's going on here. It was designed in such a way that as you worked through it, you had the opportunity to think more about it. And clearly you can't give all the information right at the beginning. It sort of has to be broken down into bits. One of the things that I was interested in is whether people changed their minds as they worked through. So we did actually capture on who changed their minds and how that kind of worked. Not many people changed their minds, but those who did are the ones who actually said yes to everything to start off with and then started to claw back. Yeah.
Very good. There was a question right in the back.
Thank you. Carol Dester from UCL. So it's to follow on really from that and to say that we've done some work with a longer term deliberative panel in relation to attitudes to newborn screening, and our experience with Sandy Oliver of working with a small panel of public over several weeks suggested that the depth of understanding attained over quite complex issues did actually make an impact. And I think that is one of the drawbacks about the width of surveys. You know, you've got the width of the population, but you probably don't have that sort of opportunity over time. One of the issues that hasn't been touched on in great depth is the implications for insurance. And I think that was something that came out very, there was a lot of concern about that it's not quite an analogous setting, but some of the work we did on newborn blood spot screening. And I think the other aspects were for people feeling that it's not so much the information that's important, but it's the transparency of the process. So I think we're focusing here very much about feedback, but I think we've also got a lot to learn about how to communicate this meaningfully to people and to make sure that they have access and transparency about it. We've modelled in Life Study our ethics framework very much on UK biobanks, but I think the challenge we still have, and I think the biobank one was beautifully written, very, very clear, is, you know, how accessible is it from people from all walks of life, really, and are we giving people levels of information that they can select to what depth they want to go, because that was the other finding from Sandy's work, that not everybody wants to know about everything in great depth, and they need a way that they can chart their own course through the information. So, sorry, it's not quite a question, but maybe the question is around both the deliberative comment from the previous questioner and also about insurance. Thank you.
Insurance was mentioned several times in the free text comments by people, you know, quite concerned about discrimination, and that was, you know, something that's in the media. People talk about that as an issue. I mean, certainly in the UK, people should not be discriminated against on the basis of a genetic test. They can share their family history with insurers, but are not allowed to be asked about whether they've had a genetic test or not, up to a certain value of insurance. Did you want to say something more on that?
Please use the mic.
There was a moratorium on discrimination in insurance, but my understanding was that that was for a defined period. I'm not a lawyer, but I think it's
2017. That's reviewed again.
It keeps reviewing every 3 years. Okay, thanks.
Okay.
Can I just say something about the communication, the delivery of results? Because we also asked about that and how people would like information delivered to them if it was serious and actionable. And interesting, this is one of the few questions where there was a gender discrimination. So women said that they would like to be spoken to in person by a clinician to have the delivery of results. And men were more likely to say that they were happy with an email or an online database.
Maybe Dan, as to insurance, because the US, of course, is the Valhalla for the insurance industry and everything. And this, has that been discussed, and what came out? And does the GINA legislation do the job, or do you need additional safeguards?
Yes, yeah, those are good questions. The GINA legislation protects from workplace discrimination and from health insurance discrimination. It does not protect against life insurance discrimination, for example. So I think people should be made aware of the consequences of return of results, notification of their physician, because a life insurance company may require the physician to disclose a genetic variant that may have implications for lifespan.
Okay, thank you very much. Many questions. Mariana, I think you were first, and then we get to you.
Thank you. I have two questions. The first one is for Dan. Dan, are you returning results from secondary research, or is it only the primary genetic research?
Can you explain what you mean by secondary research?
So, so you're doing the genotyping. Are you doing the genotyping, or who's doing the genotyping in the Framingham study?
Our genotyping may be done one of several ways, but for example, our GWAS genotyping was done through a direct subcontract with Affymetrix using the Affymetrix 550K array. We since have done genotyping using the exome chip that many of you are familiar with, which is fairly similar to the UK Biobank chip. And now we're about to begin whole genome sequencing that will be outsourced. So none of the genotyping is done in-house and could be done with a variety of different arrays or sequencing approaches.
Okay, but researchers...
we returned...
I'm sorry.
Go on.
But researchers also have access to the samples, correct?
To gain access to the samples, you would have to submit a DNA application, and that would have to, and a research committee application, an IRB approval, etc. And so when you say secondary research, do you mean research other than through array-based genotyping from a large-scale study?
So I'm talking about those results where the researcher is getting the sample from you. Are you planning to return those results as well?
The obligation of return of results, again, would apply only for actionable results. And if an outside researcher conducted genotyping, we would let them know in advance that if an actionable result came out of the genotyping, that there would be an obligation to notify participants, and that individual who commenced the genotyping would be responsible for the costs associated with the notification.
Okay.
The gentleman.
So my second question.
Okay.
So my second question actually relates to costs. For those of you who are returning or plan to return, are you also tracking the costs? I understand that the costs are going to be very context specific, as is most things in biobanking, both in terms of the nature of the biobank and in terms of how you give that information back. But there doesn't appear to be a lot in the literature about what it costs to do this. So is anybody planning to track costs or have tracked costs?
I don't know if Mike Parker wants to say something on this, but I think Genomics England are planning on doing an economic evaluation of Genomics England feedback and the implications for the NHS.
Please use the mic.
That's probably going to happen.
Okay. Thank you very much. The gentleman over there. Oops. Yeah, go ahead. Yes, with the green shirt. And then Barta. Yes. Don't worry, Barta.
Okay, the question is for Dan. I'm Massimo Angino from Twins UK. So you say that you got some criteria on what you return as genetic information, but seems always related to the person itself. What about offsprings? I'm talking about something like rare, or not rare actually, much more common, Mendelian disease, something like is a recessive one, and you are carrier. I'm thinking about something like a cystic fibrosis, yes, sorry. So what about if you find out something like a mutation which is a carrier mutation for the patient, and do you inform him or her?
Yeah, so the notion of informing a family member, that family member isn't part of our study necessarily, so the consent to inform is limited to the individual who signs the consent form, and not to that individual's next of kin, child, sibling, etc.
Thank you. Barta.
Yeah, be careful what you wish for. Going back to the issue of granularity of what it means to receive results, what kind of results, in what context, for whom, for conditions that will develop or not develop when. I'll give you a particular context, which is a bit different, but in pediatric cohorts, we have surveyed both pediatric professionals and done qualitative research with families, both for rare diseases and just general people from the public who come in for focus groups about children and return of results. And like Anna's results, geneticists, genetic counselors, and particularly in the pediatric context, are extremely careful, cautious, and conservative because they consider that it might not always be in the child's best interest to get everything and anything about some future or present or whatever. The present, they say yes. In fact, they would not allow parents to refuse feedback in studies where there's a trio, and normally parents or adults have options, and they cannot opt out to receive medically actionable information on preventable or treatable conditions during childhood. When we did the focus groups and so on with parents of both rare disease and just general pediatric issues, common across the board, bring it on. We want everything. Don't try to tell us what we can or cannot have, or when our child will be older, or when the child is now, or what we can or cannot do, or that you don't even understand what you're seeing. Just give it to us. And so that whole sort of child best interest filter was completely absent, and they said as parents, they have the authority to decide. So this feedback issue, we've got to really think about it.
Thank you very much. And then I think being in England, tea is even more important than lunch. So I really should not keep you much longer. But maybe a question for tea, because we've all seen that this is a very complicated issue. We are moving in a certain direction. But I was alerted here to another problem that we may not have thought about, because the MRC policy and the welcome policy it seems excellent to me, but if I understand correctly, it's not going to stop at the White Cliffs of Dover, but it has extraterritorial ambitions. It wants to apply to wherever MRC is funding research. And aren't we running the risk, and I know that Bart probably will speak to that tomorrow, that different projects will have different requirements and different terminology and different feedback policies? But maybe that's for the tea, because I would like to thank the speaker also then from the US very much for all their contributions. Please join me in one more round of applause for the